Good morning, everyone. I welcome you all for on this number 4 case presentation. I'd like to invite Dr. Sandeep for presenting his case. Thank you.
Good morning, respected teachers and all my colleagues. Today I'm going to present the first case of CPC. 22-year-old male resident of Dudar was admitted in RICU on 13th August 22. The date of death was 23rd August 22. Total duration of stay during the hospital was of 11 days. Patient presented with chief complaint of low-grade fever for 6 months, which was initially off and on, later continuous, which was of around 100 Fahrenheit. Joint pain for 6 months, which were bilaterally symmetrical involvement of joints with proximal interphalangeal joint, metacarpophalangeal, elbow, knee, small joints of foot. It was associated with swelling, no redness, warmth. There was no photosensitivity, no Zika symptoms, dysphagia, alopecia, or Raynaud's phenomena. Muscle weakness was present for 6 months, and he was also having generalized rash. There was history of tricough for 3 months, loss of weight for 15 kg in last 6 months. Now he presented with high-grade fever, continuous fever for last 15 days. There was shortness of breath for 15 days, which was rapidly progressive to MMRC4. There was no orthopnea, no PND, no wheeze. He was having chest pain for last 7 days, which was retrosternal in location, pricking in nature, which increased on deep inspiration. In past history, there was no history of TB, hypertension, or diabetes. Personal and family history, he was non-smoker, and there was no alcohol intake history. He was having normal bladder and bowel movement. In treatment history, there was history of alternative medications with mild improvement in joint pain and muscle weakness. For acute worsening, he received 2 days of amoxiclav and was referred to PGIM. On examination at EMPD, he was tachypneic with a respiratory rate of 28 per minute and was having tachycardia of 110 per minute. His blood pressure was 110 by 70 millimeter mercury. He was hypoxic, and SpO2 at room air was 80%. On general examination, pallor was present. There was no icterus, pedal edema, cyanosis, clubbing, or lymphadenopathy. There was subcutaneous emphysema over neck and chest. On respiratory examination, bilateral diffuse grafts were present, no wheeze. On cardiovascular, S1, S2 was normal, no murmur. On CNS examination, he was having 4 plus, power was 4 plus in all limbs. Parabdomen was soft, no non-tender, no organomegaly. And on investigation, at the day of admission, his counts, his TLC was normal, his serum electrolyte and RFT were normal, but his OTPT was slightly raised. On day 4th of admission, his TLC counts were raised. He was managed with antibiotics. He was also having hyperkalemia, so anti-hyperkalemic measures were taken. During the hospital stay, his counts were remained elevated. He was having hyperkalemia, which was initially resolved with anti-hyperkalemic, but later it persisted. On the terminal day of event, he was also having transaminitis, which could be due to shock ischemic hepatitis. In blood gas analysis, his which was suggestive of respiratory failure with PCO2 retention, and he was also having lactic acidosis in the day of terminal illness. Coming to radiology, prior to admission, 4 days before admission, he was having bilateral reticular opacities, which were more on the low zone. And this was the X-ray done prior to admission. It was of low quality. So we did the X-ray. This was the CT done prior to admission. CT was done at PGI, which was showing pneumomediastinum with bilateral GGOs. And this was the NSIOP pattern, which was seen. It is again showing the bilateral diffuse GGOs all over. And this was the X-ray done 1 day before admission, which was showing increase in pasties, and the X-ray done 1 day during the hospital stay on 14th August. This on 16th August, he was patient was intubated. On the 22nd of August, there was increase in reticular opacities, and on the both sides of the lungs, and likely due to ARDS. On etiological workup, his pro-BNP was elevated, and his myositis panel MDA5 was 3 plus, and M1-2A was 1 plus, and RO for 52 was 3 plus. On other investigations, his blood culture was negative thrice, his sputum AFP was negative, sputum PCP was negative, his H1N1 was positive, his COVID was negative. During the RICU stay, his TVT scan was negative, his 2D echo showed normal LV function, left ventricular systolic function. Coming to the course and management, he was started on ceftriaxone and azithromycin at in EMOPD and was shifted to RICU 1 day later. At RICU, initially he was kept on high flow nasal cannula at flow of 60 liters per minute and an FiO2 of 0.4. He was empirically started on IV trimethoprim sulfamethoxazole and Vislon. He was managed on sportive care once workup for PCV was negative. His respiratory failure continued to worsen. He was intubated on 16th August. X-ray showed worsening of infiltrates, and he was started on IV pulse and nebulized with cholesterol and required prone ventilation. He developed status epilepticus, was managed with anti-epileptics, could be due to hypoxemia related. He developed shock, AKI, and multi-organ dysfunction. Points of discussion: basic disease and acute worsening. 22-year-old male with polyarthritis, dry cough for 3 months, with history of rapidly worsening dyspnea over 2 weeks, and on examination was hypoxic with bilateral crackles and proximal muscle weakness and subcutaneous emphysema, was found to be H1N1 positive on investigation. His CT was suggestive of bilateral GGOs with interseptal thickening, and X-ray was showing B reticular obesities. Basic disease was CTD with myositis and ILD. Points in favor was dry cough, arthritis, rash for 6 months, baseline shortness of breath for grade 2. Radiology was suggestive of interlobular septal thickening, predominantly in the lower lobes. There was transient improvement with alternative medicine, proteinuria, and there was serologically evidence of RP-ILD. Points against was CPK was repeatedly negative. Acute worsening was due to acute exacerbation of ILD or RP-ILD, heart failure, viral pneumonia, and PCP. On acute exacerbation of ILD and rapidly progressive ILD, points favoring were worsening of shortness of breath associated with fever, hypoxemia on ABG, GGOs and septal thickening in HRCT, and subcutaneous emphysema. Points against was H1N1 positive. In viral pneumonia, points favoring were H1N1 positive, GGOs, septal thickening in HRCT, subcutaneous emphysema. Points favoring PCP were fever, dry cough, progressive dyspnea leading to respiratory failure, hypoxemia, X-ray, bilateral infiltrates, and use of alternative medicine. Points against was AT aspirate for PCP strain was negative. Left ventricular failure, points favoring were elevated pro-BNP. Points against were no orthopnea, PND, no pleural effusion, 2D echo shows normal study. Final diagnosis: myositis related rapidly progressive ILD, MDA5 associated, H1N1 pneumonia with ARDS, ventilator associated pneumonia, sepsis with septic shock with MODS.
A very warm morning to one and all. I'll be presenting the postmortem findings of this 22-year male who presented with fever, shortness of breath, history of proximal myopathy. Complete autopsy was performed in this 22-year male. At the time of autopsy, prosectors noted that the individual was thin-built. On opening the serous cavities, pleural effusion and ascites of 1 and 1.6 liter noted, and pericardial cavity was found to be within normal limits. Since the patient had history of proximal myopathy, we took consent to retrieve muscle biopsies of vastus lateralis and deltoid muscle, and they were subjected to snap frozen section. And this is one of the representative section showing a fascicle with perimysium and endomysium. At the edge, we could appreciate the frozen artifacts also. So even though there is no specific evidence of perifascicular atrophy, inflammatory infiltrate, or myonecrosis, and the endomysial vessels appears unremarkable. On further magnification, more than 10% of the myofibers shows features of internalization of the nuclei and focal areas of myophagocytosis. We performed enzyme cytochemistry, MGT stain, and NADH tetrazolium reductase stain shows normal distribution of the type 1 and type 2 muscle fibers. As a part of routine autopsy procedure, psoas muscle has been sectioned, and this is one such representative section which does not show any significant inflammatory infiltrate. There is no specific evidence to call it as florid myositis. Since the patient had a history of shortness of breath, the organ complex of interest is lung. Bilateral lung weighs 780 grams. The organ complex here is comprising of tracheobronchial tree, right and left bronchus, and a bilateral lung. Pleura appears dull. However, the cut surface is diffusely consolidated, which shows the nodular areas comprising of areas of hemorrhage, and one of the slice shows pale grayish firm zone. On lower magnification, we could hardly appreciate any patent alveoli. On a further magnification, there is an evidence of proliferative phase of diffuse alveolar damage, where we can appreciate the interstitium is markedly thickened. On further magnification, we could appreciate that the interstitium is widened with fibroblastic proliferation and fibrosis. Interstitium is the space between two alveoli, which we could appreciate here. The interstitial widening is extensive. It even extends into the alveolar spaces to form Mason bodies. This is the Mason trichrome stain to highlight the interstitial widening and fibrosis. On further magnification, we can appreciate the intraalveolar Mason body formation. At places, there is evidence of adenomatoid changes with squamoid metaplasia. A few foci shows multinucleated desquamated cell with type 2 pneumocytic proliferation. MSB stain was done to highlight any fibrin thrombi, and there was hardly any evidence of hyaline membrane changes. ZN stain, PAS and Grams Stewart was performed to highlight the presence of any acid-fast bacilli, fungal profile or bacterial colonies, however, which all turned out to be negative. RT-PCR was performed in both fresh and the formalin-fixed lung tissue by Department of Virology. We looked for presence of COVID-19, H1N1, respiratory syncytial virus and metapneumovirus. However, repeatedly, all of them turned out to be negative. We also performed immunohistochemistry on H1N1, which turned out to be negative as well. This is one of the noteworthy slides. We performed myositis immunoblot in the postmortem sera sample for muscle-specific and myositis-associated antibodies, which turned out to be strongly positive for MDA5 and anti-RO52 and faint positivity for anti-MI2A antibodies, of which the anti-MDA5 is the myositis-specific antibody, which is commonly seen in amyopathic forms of dermatomyositis patients. This is the article which got published in the Journal of Neurology. They compared the histopathological features with various myositis-specific antibodies which are seen in dermatomyositis cases. So they say that when there is a presence of anti-MDA5 antibody, there is relative paucity of features like perifascicular atrophy, perifascicular necrosis, or any inflammatory cell infiltrate. They also stressed on the clinical features and compared with the myositis-specific antibody. They found that these patients are showing higher incidence of interstitial lung disease when compared with the presence of other antibodies, and they are less frequently associated with muscle weakness and features of myalgia. So we went ahead and sampled the relatively preserved lung parenchyma, and this is the picture insert to show the normal alveolar septal thickness in an age-matched control. So if this is the normal age-matched control alveolar septal thickness, so in our patient we can appreciate that the septum is markedly widened with fibroblastic proliferation, which is suggestive of interstitial lung disease of non-specific interstitial pneumonia pattern. So in order to summarize the lung finding, there is an organizing phase of diffuse alveolar damage, possibly of viral etiology, with an underlying interstitial lung disease of NSIB pattern. So this is an article again to emphasize the association between myositis antibody and interstitial lung disease. The presence of anti-MDA5 antibodies are exclusively seen in patients with dermatomyositis, and it's associated with rapidly progressive interstitial lung disease, skin ulcer, and palmar papules. The interstitial lung disease is usually of NSIP pattern when compared to the usual interstitial pneumonia pattern, and this presence of anti-MDA5 is helpful in predicting the rapidly progressive interstitial lung disease with a specificity of 86%. A publication from the Journal of Rheumatology also found that there is an association between anti-RO52 antibody and anti-MDA5 antibodies, and they say that if there is any coexistence of these two antibodies, the disease phenotype is more aggressive, and it is essential to predict the outcome as this patient needs a risk-based therapy. Since there is so the findings are consistent with dermatomyositis, so we went ahead and looked for features of basal cell vacuolization, interface dermatitis, and dermal mucin deposition. Even after doing PA's Alcian blue stain, we couldn't demonstrate any dermal mucin deposition. Kidney weighs 182 grams. This is the organ complex comprising of bilateral kidney, abdominal part of aorta, IVC, bilateral ureters, and urinary bladder. Kidney on its outer surface and cut surface appears unremarkable. The representative image showing there is no any glomerular or tubular pathology. PA stains does not highlight any membrane thickness. Liver weighs 1600 grams and spleen weighs 70 grams. This is the organ complex which is comprising of slice of liver, C-loop of duodenum, pancreas, and the slice of spleen. Liver on its outer surface and cut surface does not show any nodular lesion or a focal lesion. Pancreas appears autolyzed. Liver appears markedly congested. A representative section from the liver shows ischemic changes with centrizonal necrosis, and hepatocytes are only preserved in the periportal area. However, the architecture is maintained, which is highlighted in this Mason trichrome stain and reticulin stain. Pancreas shows autolytic changes microscopically. Spleen was grossly congested, and microscopically there is marked expansion of the red pulp and attenuated white pulp. Thyroid was unremarkable microscopically. Heart weighs 220 grams. Appears unremarkable on its anterior and the posterior surface. However, there is focal areas of subendocardial hemorrhage, which is noted in this case. No evidence of right ventricular or left ventricular hypertrophy or thrombi noted. The representative microphotograph does not show any viral viral cytopathic changes. GIT both grossly and microscopically appears unremarkable. Brain weighs 1370 grams. This is the superior view of brain, where we can appreciate that there is a diffuse subarachnoid hemorrhage involving both the hemispheres. This hemorrhage sweeps on both the lateral sides, and it even extends into the base of the brain and obscuring the contents of interpeduncular fossa. So we went ahead and thoroughly examined the contents of interpeduncular fossa and the circle of Willis to look for any aneurysm or its rupture, but we couldn't find any such findings. And the meningeal vessels are congested. This subarachnoid hemorrhage is confined to the supratentorial compartment. The infratentorial compartment is relatively preserved. Cerebellum shows tonsillar herniation, however, no uncal herniation seen. On coronal slicing, we can appreciate this hemorrhage is extending deep into the sulci, with adjacent brain parenchyma showing dusky discoloration, indicating the hypoxic changes. This is the representative photograph showing subarachnoid hemorrhage extending deep into the sulci, and the adjacent brain parenchyma is showing hypoxic changes, which is noted in the form of eosinophilic change of the neuronal cells with pycnotic nuclei. Cerebellum also shows hypoxic changes in the form of Bergman's astrocytes. Sections from the testis, bone marrow, and adrenal gland was taken, which appears unremarkable. So the final autopsy diagnosis in this 22-year male who presented with fever, polyarthralgia, and proximal myopathy was made as myopathy not otherwise specified, with strong association of anti-MDA5 and anti-RO52 antibody and faint positivity for anti-MI2A antibody, and these findings are consistent with dermatomyositis. And lung showing organizing phase of diffuse alveolar damage, possibly of viral etiology with an underlying interstitial lung disease of NSIP pattern, and brain showing subarachnoid hemorrhage with tonsillar herniation.